Hey everyone, so here I am with another topic, hemorrhagic stroke. So, what is a hemorrhagic stroke? It's a focal neurological deficit which occurs suddenly because of a weakened blood vessel in the brain that ruptured. It's broadly divided into two, intracerebral hemorrhage and subarachnoid hemorrhage. Now, this image depicts hemorrhagic stroke. So, here you see a weakened blood vessel in the brain rupturing. Now, we're going to be dealing with the first type of hemorrhagic stroke, that is an intracerebral hemorrhage. Intracerebral hemorrhage is basically bleeding within the brain parenchyma. So, what happens when bleeding occurs in the brain parenchyma is that the blood usually collects around, forms a hematoma, and that hematoma or blood clot enlarges and applies increased pressure on the brain tissue. So, we need to know what causes an intracerebral hemorrhage. So, here we have some of the causes and the proposed mechanism underlying the hemorrhage. So, the main causes are hypertension, amyloid angiopathy, AV malformations, cerebral cavernous malformation, anticoagulant use, ischemic stroke, traumatic brain injury, and brain tumors. Out of which the most common causes will be hypertension, AV malformations, then anticoagulant use, traumatic brain injury, tumors. Now, what are the risk factors associated? Alcohol consumption, diabetes, and aging. Now, the clinical features associated with intracerebral hemorrhage is mainly a sudden onset of severe headache, which is associated with nausea and vomiting, and also impaired consciousness. Now, these three features are almost present in both the hemorrhagic stroke. That is a sudden onset of severe headache associated with nausea and vomiting along with impaired consciousness. The patient can additionally present either with seizures or he can present in coma. Now, based on the based on the area affected of the brain, there are certain features produced. So, before I go on to explain that, I'll just explain some terms used in here. Hemiparesis. Now, what hemiparesis means is that there is weakness or paralysis on one half of the body. And what hemiplegia means is that there is paralysis on one half of the body. Hemisensory loss means there is loss of sensation on one half of body. Contralateral homonymous hemianopia. Homonymous hemianopia means there is loss of vision on the same side of both the eyes, and contralateral means opposite to that of the lesion produced. Now, coming to the area affected, lobar hemorrhage. So, if hemorrhage occurs in any one of the lobes, these are the features produced: seizures, unilateral hemiparesis, hemisensory defect. The speech impairment will only occur if dominant sphere is involved, and contralateral homonymous hemianopia occurs only if the occipital lobe is involved. Now, if there is an extension to the ventricle and the subarachnoid space, the classical features exhibited is a stiff neck and meningismus. Now, if it's a thalamic hemorrhage, there can be hemiparesis, hemisensory loss, transient homonymous hemianopia. And similarly, for putamenal hemorrhage, there will be hemiplegia, hemisensory loss, homonymous hemianopia, gaze palsy, stupor, and coma. Pontine hemorrhage, the patient will present with total paralysis, deep coma, and pinpoint pupils. For cerebellar hemorrhage, the patient will have inability to walk because of imbalance. Then presents with vomiting, occipital headache, neck stiffness, gaze palsy, etc. And here, coma occurs only if there is brainstem compression and there is no hemiparesis in cerebellar hemorrhage. What are the investigations? Main investigation is you do a plain CT of the head. What does the plain CT of head show? The size and location of the hematoma, whether the hematoma extends into the ventricular system, whether there is surrounding brain edema or herniation. All of that is detected by the CT head. MRI is more accurate if you use it for chronic ICH. Now, other routine tests also should be done, like blood sugar, urea, creatinine, electrolytes, etc., to determine what is the underlying factor or cause that triggered hemorrhagic stroke or intracerebral hemorrhage. Now, how do you manage the condition? General management is you have to admit the patient in ICU. This is an emergency situation, so you'll admit them in the ICU and you make sure that their airway, breathing, circulation is secured. You give them DVT prophylaxis and make sure their nutrition is through Ryle's tube. And also, the most important thing here is that you should monitor their BP and give them IV nitroprusside or IV labetalol, and then make sure that the systolic BP is in a range of 140 to 160 mm of mercury. And if the patient is on any anticoagulant or antiplatelet drugs, it should be discontinued, and it's important that it's discontinued for at least 1 to 2 weeks. And if the person is on an anticoagulant effect, it should be reversed by giving vitamin K and fresh frozen plasma. Now, how do we specifically manage this? Now, you do surgical evacuation for all cerebellar hemorrhages that are more than 3 cm in diameter. And why do you do that is because there is increased risk for a brainstem compression and hydrocephalus, and the brainstem compression can make the person go into a coma. Now, we told increased pressure is there on the brain because of the hematoma enlargement. So, raised ICP, that is raised intracranial pressure. How do you manage it? Mannitol 20%, 100 ml IV should be given every 6 to 8 hourly, and along with that you can give injection furosemide and you can give head end elevation. Now, the patient can present with seizures provided it's a lobar hemorrhage. So how do you prevent seizures? Give any prophylactic anti-epileptic drug like phenytoin, sodium valproate. Now, hemostatic therapy is if the patient reports within 3 hours of onset of the stroke. Then you have to give the person activated recombinant factor 7A, and that is done to stop the ongoing hemorrhage and also to stop the hematoma enlargement. So the headings are: you have to do surgical evacuation provided cerebellar hemorrhages are more than 3 cm. For raised ICP, treatment should be given, and you have to give seizure prophylaxis and hemostatic therapy provided they report within 3 hours of onset of stroke. Now we are going to deal with the topic subarachnoid hemorrhage. So as you see in the picture, there are 3 layers: dura mater, arachnoid mater, and pia mater being the innermost layer. So the space between pia mater and arachnoid mater is called as the subarachnoid space. If there is bleeding in the subarachnoid space, it's called as subarachnoid hemorrhage. What is the cause of a subarachnoid hemorrhage? The most important and the most common cause is the rupture of saccular aneurysm. And then trauma is the second most common cause. So rupture of saccular aneurysm and trauma. Then AV malformation, vasculitis, illicit drug use like cocaine and amphetamine, amyloid angiopathy, and bleeding diathesis. So these are some of the most important causes. What are the clinical features? So as I said, for hemorrhagic stroke, the patient will classically present with 3 features, right? For both hemorrhagic stroke, that is, they're going to have sudden onset headache, they are going to present with nausea and vomiting along with impaired level of consciousness. So here the most important thing to note is that the headache is classically one of the worst headaches they could ever have in their life, and it is called as the thunderclap headache. So that is the name of the headache. Now, when we examine the patient, we observe that the patient has a stiff neck and Kernig sign being positive. And when we do fundoscopy, we observe that there are subhyaloid hemorrhages. What are the investigations you can do to confirm it's subarachnoid hemorrhage? The best investigation that you can do initially is a plain CT of the head, and its sensitivity is very high in the first 12 hours, after which the sensitivity decreases. So the clot gets demonstrated in the subarachnoid space. Lumbar puncture is basically done when you strongly suspect that the patient has a subarachnoid hemorrhage, but his CT scan head findings are very normal. So when you do a lumbar puncture, you take the CSF and you examine it. What you find in subarachnoid hemorrhage is an elevated opening pressure with uniformly bloodstained CSF. So this uniformly bloodstained CSF is also a feature of traumatic tap. So how do we differentiate between both? when we observe that there is clearing of blood in successive collection tubes, with the last tube showing normal CSF, suggests a traumatic trap. So if there is no clearing of blood and it stays the same in all the tubes, then it's subarachnoid hemorrhage. But if the RBC count reduces and gradually it becomes normal CSF, it suggests that it's a traumatic tap. Then xanthochromia. Xanthochromia is like one of the most important features that help you identify subarachnoid hemorrhage. It's a pinkish or yellowish tint that you see in the CSF because of hemoglobin degradation products, and it's diagnostic of subarachnoid hemorrhage. Now coming to angiogram. Angiogram can be done to know where is the lesion and what is the nature of it, and if there is any AV malformation, aneurysm, etc. Now you can go for CT angiography and MR angiography, which is actually a non-invasive method where you get to view the cerebrovascular anatomy and also to locate the exact site of the lesion. Now, how do you generally manage subarachnoid hemorrhage? Just like intracerebral hemorrhage, admit the patient in ICU. Secure their airway breathing circulation. Give them DVT prophylaxis. Ask them to go for a bed rest, stool softeners, adequate analgesia, and so on. And then you have to tell them the most important thing, that you have to discontinue the anticoagulant and antiplatelet drugs if the patient is on any. And if the patient has an anticoagulant effect, how do we reverse it? By giving them vitamin K and fresh frozen plasma. Now, how do we specifically manage subarachnoid hemorrhage? So we know here also there is a hematoma collection. It enlarges, applies increased pressure on the brain. So how do we manage raised ICP? Mannitol 20%, 100 ml IV every 6 to 8 hours. Head and elevation injection, furosemide. So here there are two things that you need to specifically prevent: seizure prophylaxis and prevention of vasospasm. Seizure prophylaxis, give injection phenytoin or give them sodium valproate, and for vasospasm give them nimodipine 60 mg every 4 hours. And now comes the main part, how you treat AV malformation and aneurysm. We told rupture of saccular aneurysm is actually the most common cause, and the second most common cause is a trauma. Now aneurysm can be treated by placing a clip across the neck of aneurysm, and you can go for endovascular techniques like coil placement for the obliteration of AV malformation and aneurysm. Now, what are the complications that you expect in subarachnoid hemorrhage? Is rebleeding. It's one of the most dreaded complications, and it can occur in the first 24 hours. Vasospasm is basically when the vessels constrict and there is reduced blood flow, and it is also a life-threatening condition. So vasospasm is a dreaded complication. Hydrocephalus happens when there is this hematoma and it extends into the subarachnoid space and the ventricles. So what happens is that this hematoma will obstruct the free flow of CSF, leading to hydrocephalus. Thank you, and I think that's all for now, and I really hope that the points prepared in the PowerPoint shown really helped you out there. Like, share, subscribe, and hit the bell button. Thank you.